Hello and welcome to Perfusion Part 1. We actually study perfusion for 2 weeks. So this week will be Part 1 where we look at the broad overview of perfusion, and then Part 2 covers more of the electrical part of perfusion. So the definition of perfusion then is the flow of blood through arteries and capillaries delivering nutrients and oxygen to the cells. In order for perfusion to happen, it requires the heart to generate a sufficient cardiac output in order to transport that blood through the blood vessels, which then gets distributed through to the tissues throughout the whole body. The scope of perfusion ranges from optimal perfusion to no perfusion. Some disorders that lead to changes in perfusion include things like some of our acute conditions, like having a myocardial infarction, a stroke, or shock. And then also chronic disorders like hypertension, heart failure, sickle cell anemia, hemophilia. And then conditions specifically that involve perfusion include neuro, so interfering with blood flow from the brain, pulmonary, which impairs blood flow to and from the lungs, and then cardiovascular, which interferes with blood flow in the heart, the arteries, and the veins. So causes of these disorders can include things like congenital defects, in other words, something that we're born with. It can be genetic disorders. There can be injury, inflammation, infections can all lead to some of these situations where we have impaired perfusion. We're going to look at the two big categories of perfusion, which is central perfusion and tissue perfusion. So central perfusion is generated by cardiac output. So cardiac output then is the amount of blood that it gets pumped by the heart each minute. And that's probably a good term to remember, cardiac output. So this propels blood to all the organs and their tissues from the arteries through the capillaries and returns the blood to the heart through the veins. Another term that you might want to remember the definition of is stroke volume. So stroke volume is that volume of blood that gets pumped out of the left ventricle of the heart during each systolic cardiac contraction, okay? So a little bit different from our cardiac output, but both can have an impact on each other. All right, so when we take a look at central perfusion, we have to think about what makes the ventricles contract. All right, and we'll take a more in-depth look at this again next week. But the electrical part of the ventricles contracting starts in the SA node. This is where our normal heartbeat originates from when we have normal conduction. So it starts in the SA node, travels to the AV node, moves through the bundle of His and the Purkinje fibers. So when the ventricles contract, this is called systole. Okay. Another factor that can affect cardiac output is systemic vascular resistance. So another one of those fancy $10 medical terms. We usually label that SVR. So SVR is the amount of resistance within the vasculature that the heart pumps against. So think about the diameter of the artery, the lumen, okay? And so think about things that would cause a higher resistance. So if our patient has a lot of plaque inside those arteries, that plaque builds up. That creates more or a higher systemic vascular resistance because the blood doesn't have as much of a diameter to flow through, to be pumped through. So when we look at impaired central perfusion, this occurs because of a decrease in that cardiac output that I talked about previously. So when that blood supply to the tissues is impaired because of cardiac output, blood loss, or vasodilation, any three of those things, then we can have consequences. All right, so those consequences then can impact the entire body. So let's think about shock. So we generally think about, about three different types of shock. Cardiogenic shock means the heart is unable to pump. Hemorrhagic shock, because we have a profuse loss of blood, we can have shock. So when we have a profuse loss of blood, think about things like gunshot wound, stabbing wound, a bad automobile wreck, those types of things, okay? We can also have systemic vasodilation, meaning that we have vasodilation throughout the body, systemic meaning throughout the body, and this can lead to a decreased blood flow to the brain, the heart, and the kidneys when everything vasodilates at once, okay? So we can have different types of systemic vasodilation, meaning we can have anaphylactic shock, we can have neurogenic, we can have septic shock, okay? And then another thing that can impact that is if we have a myocardial infarction, which is, the fancy medical term we use for heart attack. So if I have an occlusion or, a narrowing of those coronary arteries, I can end up with a heart attack that can impact central perfusion. And then the other thing to think about, the other structures are the heart valves. So if I have either stenosis or insufficiency with those heart valves, then I can also have an impact to my central perfusion. So ischemia occurs when the blood supply is available, but it's decreased. All right, so a prolonged ischemia of the tissues then can lead to necrosis or infarction. So, so I can have ischemia to my distal extremities, right? So think about, where I'm not getting good blood flow because of other disease processes, a wound, a blood clot, those types of things. I can have ischemia to those tissues. If I have a blood clot or buildup in the coronary arteries, I can have an infarction. Okay, so that interrelationship between the cardiovascular and the respiratory systems, because cells are deprived of oxygen from that lack of blood flow and from that lack of oxygen, or both. So when you think about ischemia, so not only is it that might be a lack of blood flow, but it can also be a lack of oxygen, because remember, my oxygen is carried in my blood. So I've got a restriction somewhere when I have ischemia, and this can happen to tissue, to muscle groups, to organs, and I'm probably going to have that shortage of oxygen that is needed for that cellular metabolism. Okay, I have to have oxygen and blood flow to keep those tissues alive. All right, so let's do just a kind of a knowledge check. Which condition related to heart failure causes fatigue? Would it be A, impaired renal perfusion, B, increased pulmonary pressure, C, decreased oxygenation to the tissues, or D, reabsorption of fluid from dependent body areas? So we're going to look at our question, and it's asking about, it's wanting you to key in on fatigue related to heart failure. Those are my key words, okay? So we can see that we have C is our answer, so decreased oxygenation of the tissues. So fatigue is caused by that decreased oxygenation of the tissues. Dyspnea, not fatigue, is caused by increased pulmonary pressure. And then impaired renal perfusion resulting in decreased urine output during the day is a cause of nocturia, not fatigue. And then paroxysmal nocturial dyspnea is caused by reabsorption of fluids from the dependent body areas when the patient is lying flat. Okay, so just some things to think about as we talk about perfusion. Okay, so let's look at tissue perfusion. So we looked at central perfusion. So let's look at tissue perfusion. So this refers to that volume of blood that flows through those target tissues. And this blood is supplied by blood flowing from the arteries to the capillaries. So if I have inadequate tissue perfusion, this can result from poor central perfusion or from a mechanism within the organ itself, such as a blocked blood vessel leading to or from that tissue, or from excessive edema within the tissue. All right, so impairment of tissue perfusion is associated with three things: occlusion, constriction, or dilation of arteries and veins. So when we look at occlusion, we can think about things like atherosclerosis, where that plaque gets built up inside those arteries, or a thrombi, where I have a blood clot. I can think about constriction. So an example might be with frostbite. Or I can think about dilation, like things like an aneurysm, okay? So when we look at this perfusion triangle, there's really kind of three things to think about. The heart, which acts as our pump, so damage to the heart by either disease or injury. So if it cannot move blood adequately to support perfusion, all right? So think about an enlarged heart where it's not pumping adequately, okay? Then I also have to think about blood vessels. So the blood vessels are the container function. So if all those vessels dilate at once, the normal amount of blood volume is not enough to fill that system and provide adequate perfusion to the body. So remember when we talked a few slides back about shock, those types of things, where there's just not enough blood because everything is dilated at once. And then I also have to think about blood, which is my content function. Okay, so if blood or plasma is lost, the volume in the container is not enough to support the perfusion or the needs of the body. All right, so this is kind of that perfusion triangle where I think about the heart being my pump, the blood vessels being my container, and blood being the content. So let's take a quick look at some of our risk factors. When we think about risk factors for perfusion issues, we generally break those down into modifiable versus unmodifiable, okay? So modifiable meaning those things that the patient can have some impact, some control over, all right? So these are things like smoking. And most of our patients are going to say, wow, I really just think about smoking maybe causing some lung cancer someday. But smoking is so incredibly hard on the blood vessels. So the blood vessels to the heart, especially the blood vessels in the lower extremities. And so nicotine is very bad for that situation. So we really want to encourage our patients, if they're smoking, vaping, chewing tobacco, any of those processes, that we encourage them to quit smoking. So elevated lipid levels. So these can contribute to atherosclerosis, that buildup of plaque inside the arteries. And so patients often have some control over that. They can take their meds, they can adjust their diet, they can exercise, all of those things that can impact those lipid levels. A sedentary lifestyle. This also contributes to obesity frequently, and both are not good for perfusion purposes. All right, so encouraging our patients to exercise. Obesity. So obesity increases the risk for type 2 diabetes and for that plaque buildup, atherosclerosis. We know that our type 2 diabetics are very, and type 1 are very prone um, to perfusion issues. Diabetics just do not get a fair shake when it comes to a lot of these issues that can occur. It puts them at a bigger risk. And then, just like I said, diabetes increases that risk for that plaque buildup. Hypertension. Hypertension increases that workload of the myocardium, and we'll have a lot of patients who don't like the side effects of their hypertensive medications, and they'll quit taking those. And you really want to educate your patients about this to continue taking them. Usually after a couple of weeks, those side effects will go away. And if not, there's lots of medications out there to treat high blood pressure. So encourage your patients that if you absolutely cannot withstand the side effects of those meds, then talk to their healthcare provider about changing to something different. And then the last modifiable risk factor is trauma, which can lead to blood loss, which we know can lead to shock. And you might say, well, how on earth would trauma be a modifiable risk factor? And it has to do with managing your risk. So if somebody is living a very risky lifestyle, there's somebody who doesn't wear their seatbelt, they drive fast, they don't pay attention to traffic laws, they hang out with a higher risk crowd, they go skydiving, all those things that can put somebody at a higher risk. And then we have our unmodifiable risk factors. All right, so the risk for perfusion issues greatly increases with age. Men generally have a higher risk factor than men. However, once women reach menopause, because they think menopause is what protects women from earlier onset, but once women reach menopause, they don't have those same protections either. And so they start to have a bigger risk as well. And then we know that family genetics, family history, plays a big role when we talk about cardiac issues. So our nursing assessment should include things about their diet. What do they eat? And not just asking, hey, do you have a healthy diet? Because what's the answer going to be? Oh, yeah, of course I do. So you want to ask, tell me what you had yesterday for dinner. Tell me what you had for lunch. Those kinds of things. How often are you eating out? Where do you go to eat out? What do you get when you eat out? Because we know that that diet plays a big role in risk for cardiac issues. The family history, as I just talked about previously, exercise, smoking, including vaping. We know that vaping has been on the scene for a shorter amount of time. We don't have a lot of data yet, but what we are seeing is showing that it has some pretty detrimental health effects. What kind of work do they do? What kind of environment do they work in? Is it sedentary type of work? And then, what are they doing for exercise? ETOH is one of those fancy $10 medical terms for alcohol. And alcohol use, especially if it's, above that moderate, so usually we think one drink for women and 2 drinks for men. So if it's above that, and especially if it's frequent, or if they're even doing, a lot of binge drinking, both are very detrimental and have some cardiovascular risk to them. And then take a look at their medications, and remember to include over-the-counter meds. A lot of times they think, oh, if they're taking vitamins or other supplements, that it's not important to mention those. And sometimes there could be some pretty bad interactions with some of their other medications. So it's always a good idea to get an idea of what they're taking over the counter and those herbal supplements. A lot of times also just reviewing their prescriptions because they'll forget to tell you things that are in their medical history, and sometimes looking at their medications can help clue you into, oh, hey, why are you taking this med? Oh, yeah, that's my blood pressure pill. Oh, okay, so you've got high blood pressure. Um, so a lot of times they'll forget, and sometimes looking at those meds can help clue you into what's possibly going on as well. And then ask the patient, where do you sleep? So are they having to sleep sitting up in a recliner? That's another big red flag. How do they sleep? Are they getting up a lot at night to use the bathroom? A lot of times, if they've got nocturia, meaning getting up at night, a lot of times that's because they're not processing that fluid during the day. So when they lay down, that fluid is becoming an issue at night. And then have they noticed changes in their energy level? Fatigue is one of those overlooked signs and symptoms, especially for women, that can be overlooked. So if they've had some new onset fatigue, one of the things you want to really look at is, do we have a cardiac issue? Have they had unexplained weight loss or weight gain? Um, a lot of times we'll see weight gain when they are holding on to a lot of fluid as well. And then pain, we really want to assess that pain. Pain is more than just a number on a scale. Pain also, is this coming and going? Are you noticing pain with exertion? What makes that pain better? Where are you feeling that pain? Because we know that pain often happens in the jaw, the neck, the chest, can radiate to the arms. So you really want all those aspects of that pain. And swelling, like I just said, a lot of these patients can hold on to fluid. Have they been feeling faint? Have they had history of falls lately? Sometimes this can happen with orthostatic hypotension. So again, really want to clue in on some of those symptoms as well. And then feeling short of breath. Remember that your respiratory system and your cardiac system go together like peanut butter and jelly. And so you really want to assess both of those situations. So the physical assessment, you really want to look at those vital signs, carotid pulses, the capillary refill time, do they have edema, and then your respiratory. Are they short of breath? Is their O2, what's their O2 sat like on room air? And then neuro is our other system that really has to be assessed when we talk about cardiac issues as well. So is this person having confusion? Um, uh, and then check their sensation. What is their speech like? Are they dizzy or fainting? And then, like I talked about with the pain, you really have to assess all aspects of that pain. GI and GU, what is their output? Are they, again, are they having nocturia? Are they having, holding on to a lot of fluid? What has their output been? Okay. All right. So this slide is kind of one of those, um, some people learn better if they can have a picture that they keep in mind. So the first one is kind of a saying to help you remember how to listen to the heart. So this one says down here at the bottom, it says, all people enjoy Time magazine. Okay, so the A stands for aortic. So you start over here and listen to the aortic first, over that aortic area. Then you move over to the pulmonic. All right, so the P in people stands for pulmonic valve. All right, so now we've moved, so aortic on the just to the right of the sternum, pulmonic over here just to the left of the sternum. Then we move down to Erb's point, and then we move down to the tricuspid, and then the mitral. So the mitral is all the way down here at the apex of the heart. All right. So this is just a reminder of how you listen to the heart in a specific order. Okay. Probably a good thing to keep in mind. We're getting close to that point in the semester where you will do your head to toe assessment, and part of that assessment will include your cardiac assessment. So, learning how to listen to that heart in the correct order is important. Okay. So this picture on the right kind of gives the visual of where you listen in between the ribs, okay, the intercostal spaces. All right, so here is your aortic up here at that second intercostal space. Here is your pulmonic. Again, we're at that second intercostal space, but now we're on the left side of the sternum, okay? And then Erb's point, we come down to the third intercostal space. Then we come down to our tricuspid, which is our fourth or fifth intercostal space. All right. And then, like I said, we've got the mitral area, which is the fifth intercostal space at the mid-clavicular line. So here's the clavicle across here, and we're at the mid-clavicular line down to that fifth intercostal space. All right, so this is also the apex of the heart. So there's several labs and diagnostic studies that can be really helpful in helping us figure out what is going on and assessing our patient. So some of those are CKMB, so creatinine kinase. So the CKMB is specific to myocardium. Okay, so that one is specific. When we talk about myocardium, that's specific to the heart. There's also a CKMM, which is muscle, and a CKBB, which is brain tissue. But when we're looking at issues with the heart, we definitely want to look at that CKMB. The lactase dehydrogenase, LDH, is found in large amounts in the heart, the liver, and the muscles. Troponin. So troponin is very specific to the heart. And if it is elevated even a tiny bit, this is indicative of an MI that is currently occurring. Okay, so if we have patients come into the emergency department, to the cath lab, those kinds of areas, we're always getting the CKMB and those troponin levels so that we can see if somebody is actively infarcting. Okay, so again, troponin very specific to the heart, and like I said, it's a very small number, so anytime there's an elevation in that troponin level, they're actively having a heart attack. So this BNP, we'll often look at that one if we're suspecting somebody has heart failure. CRP, C-reactive protein, it usually produces inflammation. It's elevated when there's inflammation. Of course, our lipid panel, when we're looking at cholesterol levels. HCY is our homocysteine levels that we'll often look at as well. And then we definitely want an EKG to see what does that electrical part of the heart look like. We may do a cardiac stress test. We only do those stress tests once these troponin levels have come back and they're normal. You would not want to do a cardiac stress test on a patient who has an elevated troponin level. Those patients with the elevated troponin levels are having an active MI. So you would never take that patient and do a cardiac stress test on them. They need to go to the cath lab, to the cardiac cath lab, and get those blockages fixed if at all possible, and then if not, they'll have surgery. So when we do cardiac stress tests, we can also do a pharmacological stress test if they're not able to walk on a treadmill. Again, it would be the same. You don't take patients who have elevated troponin levels to do a stress test. And then there's several radiology exams, chest x-ray, ultrasound, an arteriogram. So let's do a quick knowledge check. A patient presents to an emergency department with angina. So angina is one of those fancy $10 medical terms meaning chest pain. Which parameters in the laboratory report would indicate a myocardial infarction, otherwise an MI or a heart attack? And you select all that apply. Is it A, high troponin levels, B, high cholesterol, C, elevated homocysteine levels, D, an increased CRP, or E, an increased creatinine kinase, a CKMB? Okay. So hopefully you were able to come up with troponin and the CKMB, all right? Again, CKMB is going to be very specific to the heart. Troponin levels, if they're even slightly elevated, very specific to the heart. So those are the ones that that could be very indicative of a myocardial infarction, a heart attack. Okay. The other, like a high cholesterol level, puts you at a higher risk, but it's not specifically saying that, yes, this person's having a heart attack. And then the other ones look at things like inflammation, which again is usually present with a heart attack, but these would not be specific to a heart attack. Those can be elevated and not be a heart attack. Okay. All right. As always, please reach out if you have any questions. We're here to help. You just have to let us know. And then if you are doing the discussion board, you can always come back here to look at those references. These have to do with your Concepts of Nursing Practice book and your Med Surg book.